Good afternoon, everyone. It's Adrian. Thank you for this very kind introduction. And I'm honored to be on this panel with Dr. Aidi and Dr. Chang. So the GERD is a very common disease. We don't need to belabor that point. But it's important to emphasize that GERD is not a hypersecretory disorder. That means we don't reflux because we're making too much acid. That means we don't reflux because we're making too much acid. We reflux because there's a defect in the anatomic barrier that prevents the reflux between the stomach and the esophagus. So it's very important to classify the disease based on anatomy as the first step of offering therapeutic options. And this could be a spectrum. You could find mild alteration in anatomy, and most of the reflux is secondary to these transient lower esophageal sphincter relaxation. So mostly the valve function of the GE junction is normal, and these patients could be managed with PPI unless they do not want to be on long-term PPI. But what's important is to carefully evaluate this area and detect these early and advanced anatomical changes of the GE junction that makes it a constitutionally open area and promote reflux that would be better served with a procedure that could repair this barrier function of the GE junction. So again, here is the important classification that all of you need to be looking at and reporting in your upper endoscopy. In a normal scenario, in a normal function, there is this lip valve function of the GE junction. It's a high pressure 2 centimeter zone. In a retroflexed insufflated position, you see that the GE junction is hugging your scope. There's no gaps. There's no changes with inspiration or expiration. And this is normal anatomy or Hill grade 1. These are the mild alterations that are critical to identify because these could benefit from a procedure such as TIF without a repair of the diaphragmatic hiatus. And this is the Hill grade 2. And basically with the Hill grade 2, you have shortening of this lip valve function. And the most of the shortening happens with inspiration, expiration. So if you just retroflex, insufflate that area, spend a few extra seconds looking at a few cycles of inspiration and expiration, what you will see is the valve will intermittently open and shorten with this inspiration and expiration, and that will indicate a mild defect in the hiatus and a Hill grade 2 valve. Now, Hill grade 3 is a gray zone, and this is you're now in the territory of what Dr. Aidi will be talking about, where you're going to be repairing the hiatus plus offering a TIF afterwards, not just a primary TIF. And with Hill grade 3, you have complete effacement of the valve function, and you have a constitutionally open valve. And with Hill grade 4, you have herniation of this entire complex above the diaphragm. It's very important that everybody gets this crystal clear because that's what's going to determine effective management of your patients, whether you offer medication, TIF as a primary procedure, or a concomitant hiatus repair plus a TIF procedure. So we all agree that we need to repair this valve function, and these are the principles of a successful fundoplication, whether done endoscopically or laparoscopically. One is, if you have a small hiatal hernia, you want to reduce or repair it, and the threshold here is 2 centimeters. You want to elongate the intra-abdominal esophagus in order to create this lip valve function and this high pressure zone. And you want to create a fundoplication that will tighten this intragastric portion of the esophagus and create a high pressure zone that is not conducive to reflux. So let's see how the TIF procedure with the esophagus device could produce these principles of anti-reflux surgery. This is the iterations of the evolution of this device. I put it here because it's important for you to start thinking when you're reviewing the literature which version of the TIF procedure have been described in what study, because we're in order to have a better understanding of the literature. So the device evolved over time with the first generation producing a gastrogastric application. Then the device evolved again to the TIF 1.0 procedure that is now enabling a gastroesophageal plication, not just a gastric plication. And the most recent iteration, which is the TIF 2.0 procedure, produces a gastroesophageal plication plus a wrap function. Okay, so this is the evolution of this technology, and we're currently at the TIF 2.0. This is a cartoon that demonstrates this. If you look at the color schematics, this is where the high pressure zone that you're creating. In a normal anatomy, you have a high pressure zone that is above the Z line. In a GERD patient, you could see that this high pressure zone is diminished. With the first iteration of the procedure, with the ELF procedure, they were creating a gastrogastric plication. So the high pressure zone was lower than the region that was desired. Then the technology evolved to the TIF 1.0 procedure, where now you are capable of creating a gastroesophageal plication, thus that's causing a higher pressure zone slightly above what the ELF procedure was capable of doing. And with the TIF 2.0 procedure, you are now creating a gastroesophageal plication plus a wrap function that resembles a surgical fundoplication with a higher pressure zone that is preventing reflux. So this evolution of the procedure is very important to interpretation of the literature. So if we could see from the schematics that I showed you, now with the primary TIF procedure, we could reduce small hernia and tack it to below the diaphragm. With the concomitant TIF plus hiatus repair, we could do the same after closure of the crura. We could elongate the intra-abdominal esophagus, and we now are capable of creating a fundoplication. So really, we have respected all the principles of an anti-reflux procedure. This is how it's done. It's done through these T fasteners that are deployed in a semi-circumferential 270 degrees around the GE junction in order to create these, this 3 centimeter high pressure zone and the 270 wrap. This is an example. This was actually, if you look at this picture, you could say that this is a borderline case. This was really a Hill grade 3, actually, but it was very easily reducible. You could see maximal insufflation. It's open. It's not snug on the scope, and it does not really change too much with inspiration expiration. However, with the procedure, we're able to elongate or pull the esophagus to an intragastric position and start creating the strap. You could see the rotational aspect of this device allowing for wrap creation. And we went from an effaced valve with a constitutionally open GE junction to a 240 to 270 wrap with a high pressure zone and with a bulkiness that would prevent reflux. Again, I'm very skeptical, so usually I do multiple studies to ensure the anatomy is correct. So in this patient, we did get a CT scan, actually, and CT scan with contrast beautifully defined this anatomy. You could see that the CT contrast is fully inflating the stomach. You could see here the esophagus with no reflux in the esophagus, and you could see the slip valve function, if you measure it, is about 34 millimeters. So what about data of efficacy and safety? I only summarized the randomized controlled trials. There's 4 of them. It's very important when you review these trials, and actually there's going to be a publication in gastrointestinal endoscopy that goes over the literature in great details. It was accepted actually this week. But these trials usually are comparing the TIF 2.0 procedure to either PPI or sham or double PPI or double placebo and sham. And generally, they have investigated PPI responsive patient with a positive pH of medication. Some of them investigated PPI non-responsive patients. So it's very important to keep these baseline characteristics when you interpret the literature. But the primary outcomes have been good, and they mostly look at improvement in GERD, health-related quality of life questionnaires, and you could see there's robust, significant improvement in these questionnaires compared to either an open label or a sham procedure. Then they looked also at abnormal acid exposure with pH study, and compared to sham, you could see significant improvement in this parameter as well. But most of the literature also report on rates of erosive esophagitis healing, and that have ranged between 70 to 94% in the reported literature, with a rate of PPI discontinuation after the procedure that goes from 59% to upward of 74%. So these are the trial data, and now we have data that goes beyond that. These were all mostly 6 to 12 month data, but now we have 3 studies: the TEMPO extension study that looked at the outcomes after the TEMPO trial at 60 months. Then we have a trial that looked similar in 45 patients at the outcomes also in 60 months. And we have a limited case series that looked at 10 years results. And in general, the rates of PPI discontinuation continue to be in the neighborhood of 60 to 70%. Patient satisfaction continue to be high. So now we have data to show that the anatomical manipulation that we created with this procedure continue to be durable. Safety is of primary importance, so safety have to be perfect. And I think with the new iteration of the device, out of 22,000 commercial cases, 89 adverse events were reported, giving it an SAE rate of 0.4%, which is in par with any other endoscopic procedures like colonoscopies with colpectomy, for example. So in general, the safety has been quite good. I will stop here and give the podium to my colleague, Dr. Aidi.